surgery in high myopia. My name is Marcus Ang, and I'm the Clinical Director of the SIDC Myopia Center and a cornea refractive surgeon at the SNEC. Thus, many of my patients present to my clinic with anterior segment complications related to myopia. These are my financial disclosures. We all know that myopia is set to affect billions globally, and we estimate that up to 1 billion may be suffering from high myopia in the next few decades. This is not just a problem that will affect Asia, but also many populations around the world. Myopia is also the most common refractive error that's uncorrected, affecting millions of children and adults as one of the key causes of reversible visual impairment. This has been found to have impacts not only on visual function, but also education and quality of life. More importantly, myopia and especially high myopia can lead to complications that can cause irreversible visual impairment. These include myopic macular degeneration and myopic optic neuropathy. These complications can affect persons with all severities of myopia, with the risk of visual loss increasing with age. Thus, it's important to prevent the development of myopia in young children, but also progression to high myopia even in their teenage years. The impact of myopia as a refractive error and its potential complications has huge public health implications. Myopia doesn't just affect children, but also affects productivity in adults. Their quality of life may be affected by high myopia not just as a refractive error, but also be affected by the early onset of common anterior segment complications such as cataracts. To illustrate, I'm going to share 3 patients who came to my clinic in the last 1 month who required some form of anterior segment surgery related to high myopia. My first patient is a 23-year-old lady who has been myopic since the age of 6 and has progressed to more than -10 diopters, remaining stable in the last 2 years. She struggles though with the quality of vision from her glasses and is uncomfortable with contact lenses. She has come to my myopia clinic seeking a refractive surgery solution to treat her high myopia, which is affecting her quality of life. In recent years, laser refractive surgery has evolved from surface ablation to LASIK, and more recently, small incision lenticular extraction or SMILE. These techniques have become a safe, predictable, and effective treatment for myopia. However, for many high myopes of more than -10 diopters, corneal refractive surgery may not be an option due to the amount of ablation of corneal tissue balanced against the risk of ectasia. Thus, implantable phakic intraocular lenses, or more commonly, implantable Collamer lenses, have become a feasible alternative for high myopes. However, accurate preoperative assessment of eyes before ICL implantation is really important. A minimum anterior chamber depth of 3 mm is recommended, but not as common as we think in high myopes. Accurate measurements and sizing of the ICL implant requires precise corneal white-to-white measurements or sulcus-to-sulcus measurements based on either OCT or UBM imaging. The most common and significant complication of ICL implantation is cataracts. Thus, ICL insertion and proper placement with an adequate lens vault is important to reduce the risk of anterior subcapsular cataract formation. The FDA clinical trial reported a 0.4% risk of ASC cataract formation and a 1% risk of nuclear sclerosis cataract. It is also important to note that patients with a higher degree of preoperative myopia had a higher rate of complications with associated loss of vision or loss of lines. The recommended postoperative vault is between 250 to 750 microns, with most surgeons targeting a 500 micron vault, as illustrated by my patient over here. A vault greater than 750 microns risks pupillary block glaucoma and crowding of the angles with possible pigment dispersion. My second patient is a 40-year-old high myope whose baseline myopia is -20. Actually, she's a doctor, and she's been noticing that her myopia has been increasing in both eyes for the past few years. On examination, I found significant nuclear sclerotic cataracts leading to index myopia in both eyes. The incidence of cataracts increases with the increasing severity of myopia at a younger age. At the myopia center, we often see patients who are in their early 40s or 50s with early onset of cataracts leading to index myopia or anisometropia. This often affects their already compromised quality of vision, and sometimes optical solutions no longer provide optimal visual correction. However, early removal early cataract removal in high myopes may have a risk of retinal detachment after surgery and should be discussed with patients. The prevalence has been reported in up to 4% or even 8% depending on the studies, with an approximately six times greater risk of RD compared to more non-myopes, and a much greater risk in patients younger than 55 years of age. Accurate biometry is also an issue for high myopes with long axial lengths, as accurate measurements of the eye can be challenging. This can be due to asymmetrical axial elongation or the irregular shape of the posterior segment. Moreover, traditional biometric formulas do not estimate the effective lens position well in eyes with long axial lengths. Although in recent years, the Kane and Olsen formulas have been found to perform better than the Barrett's, producing the lowest prediction formula and the highest percentage of eyes achieving target refraction, so formulas for high myopia is improving. My last patient is another typical patient referred to my practice for potential anterior segment complications. He's a 40-year-old scrub nurse who is a high myope and had undergone LASIK, now rapidly developing anisometropia. In such cases, patients are often referred to me to exclude post-LASIK ectasia, which fortunately he does not have. However, he does have significant cataract in one eye, and optical solutions such as contact lenses versus early cataract surgery should be discussed. Counseling again about the risk of early cataract surgery in high myopia, refractive surprise, and the effects of early presbyopia. On top of this, biometry in post-LASIK eyes with long axial lengths present a different set of challenges in order to predict patients' refractive outcomes after surgery. A recent meta-analysis suggested that formulas that include OCT-based keratometric measurements may be more predictable compared to traditional regression formulas such as Haigis-L. More recently, swept source OCT has been used to directly measure the anterior and posterior corneal surface combined with telecentric keratometry to provide a more comprehensive assessment of the cornea in post-LASIK eyes. In summary, I've presented patients who have compromised quality of life from high myopia or their complications. While anterior segment surgery can be a solution, the risks and benefits should be carefully discussed, while special consideration in view of their high myopia should be made in order to achieve an optimal refractive outcome. I thank you for your attention.
Good morning. I would like to thank the organizers and the scientific committee for giving me this opportunity to participate in this symposium. I would like to give you a brief overview of myopic maculopathy, mainly based on the latest research, as well as those masterpieces in pathologic myopia. As we all know, pathologic myopia is characterized by the presence of myopic maculopathy and posterior staphylomas. There are many researchers who have made a great contribution in exploring the various lesions of myopic maculopathy. There was no standard grading system until MetaPM classification was proposed. Everyone must be familiar with this table. Pathologic myopia was defined as equal to or more severe than the diffuse atrophy. The MetaPM classification has been universally accepted by all over the world. Myopic maculopathy is very important because it is often bilateral and irreversible. It frequently affects the patient during their productive years. I will talk about each of these lesions in a moment. First of all, tensillated fundus is one of the earliest visible signs in high myopia, and it is the most common finding in children. Tensillation is a relatively stable condition and might stay for a relatively long period. Diffuse atrophy is one of the most common lesions among the myopic maculopathy. It is seen as ill-defined yellowish lesions. Its primarily occur in the peripapillary regions. Now we call it peripapillary diffuse choroidal atrophy (PDCA), and eventually extended into the whole macular area called macular diffuse choroidal atrophy (MDCA). In the OCT images, diffuse atrophy is observed as extreme thinning of the choroid. However, even in the area where most of the choroidal layer is absent, can be seen as 12 microns, the RPE layer and the outer retina are still preserved. Brooks membrane is considered intact, but the extreme thinning of the choroid may make Brooks membrane fragile, and this may facilitate other lesions to develop later. The diagnosis only relied on the color is subjective because the fundus colors may look different according to the degree of fundus pigmentation among the races. Here are some typical fundus photos of tensin lesion, PDCA, and MDCA with corresponding OCT images. You can see all of those types of myopic maculopathy are influenced by how thin the choroid is. By using the statistical analysis, we found that the cutoff value of choroidal thickness to predict the PDCA is 56.5 microns nasal to the fovea. The subfoveal choroidal thickness of 62 microns can be used for distinguish MDCA from PDCA. The next lesion is patchy atrophy. It's relatively easy to be observed. It rarely involves the fovea itself. In OCT images, RPE and the Brooks membrane stop at the site shown by these arrows. In most of the case, you may also notice that the RPE stop outside the margin of Brooks membrane defect. So actually, the patchy atrophy was not simply an atrophy, but extrafoveal Brooks membrane holes. Recently, we also found there is a high prevalence of vessels, we call it abruptly emerging vessel, that continues with perforating scleral vessel in patchy atrophy, which indicate the possible mechanism on how Brooks membrane is ruptured. Based on our 18 years follow-up study, almost all eyes with patchy atrophy show a progression, including an enlargement of original patchy atrophy, the development of new patchy atrophy, CNV, and patchy-related macular atrophy. Lacquer cracks, a plus lesion, do not fit into any particular category. They are fine, irregular, yellow lines showing the characteristic presentation by different imaging modalities. It developed at a relatively early age in highly myopia patients. Only using fundus photographers is clearly not enough for detecting the lacquer cracks. Using multimodal images, over 50% of the eye with lacquer cracks has a progression during 3 years. An increase in the number of lacquer cracks was the most frequently pattern, followed by the progression to patchy atrophy. Myopic CNV is the most frequently cause of central vision loss. It developed around 10% of highly myopic eyes. Without any treatment, most of the cases eventually progress to the atrophic phase, CNV-related macular atrophy. By using the web source OCT, it also showed that the CNV-related macular atrophy was not simply an atrophy, but foveal Brooks membrane holes. The pathogenesis of myopic CNV is not well understood. Recently, we found that the scleral perforating vessel was just below or around the CNV in most of the cases. The ICG also confirmed that those perforating vessels were intrascleral arteries from the short posterior ciliary arteries. It indicated that there is a possible connection of the SPCA to CNV through the defect of the RPE and the Brooks membrane. The origin of new vascularization might be not always from the choroid, so the term myopic macular neovascularization should be more appropriate. So lastly, I would like to show the progression pattern of myopic maculopathy and the corresponding potential pathogenesis. At first, the tensillated fundus is not counted as a stage of pathologic myopia because it does not cause the visual impairment. The diffuse atrophy started in the peripapillary regions and extend to the macular area. The progression is highly associated with choroidal thinning, so the nasal and the subfoveal choroidal thickness can be used to diagnose the PDCA and MDCA. The patchy atrophy has a hole in Brooks membrane that often formed by an enlargement of the lacquer cracks or derived from the diffuse atrophy that Brooks membrane might be fragile. The macular atrophy is almost always MNV related, although the patchy-related macular atrophy can occur very occasionally. In summary, mental PM classification have been widely used and it becomes a standard for comparing the results of different studies. Progressive and continuous choroidal thinning play a key role in the progression from no myopic maculopathy to tension-related fundus and to diffuse atrophy. The choroidal thickness can be an alternative for diagnosis PDCA and MDCA. The lacquer crack, CNV, patch atrophy, and macular atrophy are all associated with Brooks membrane defect. The origin of the neovascularization in pathologic myopia might be not always from the choroid. Thus, the term myopic macular neovascularization (MNV) should be used. And thank you very much for your attention.
Good afternoon, everyone. Thank you very much for your time on my presentation. My topic today is deep learning approach for automatic detection of myopic maculopathy and pathologic myopia. It has been widely concerned that the prevalence of myopia and high myopia have been estimated as the temporal trends from 2000 to 2050, in which means more than 4,570 million people will suffer from myopia by 2050, and even 937 million people with high myopia. Myopic maculopathy have been highlighted as a major cause of irreversible vision loss. It is well known that MetPM study group have classified myopic maculopathy into 5 categories: normal eyes, tetralysis fundus, diffuse atrophy, patch atrophy, and macular atrophy. But an accurate diagnosis of myopic maculopathy as well as pathologic myopia is often difficult, especially for non-specialists. Myopia-related blindness increases in many parts of the world in the near future. A lack or shortage of myopic retina specialists has been and will be a huge concern. So automated grading system of myopic maculopathy is necessary. So the purpose of this study is to create an automated manner to detect pathological myopia and categorize myopic maculopathy by fundus images. We mainly collected fundus images from Tokyo Advanced Myopia Center between 2014 January and 2018 March. All images were focused on fovea. In data grouping, over 5,000 images were collected. To avoid image bias, 2 images per eye were used in training and validating. We also spared 1,844 images for testing the performance of models. 1 image per eye was used, and these images will never appear during training and validating. Data were further processed through data standardization and augmentation. Then, models were constructed by EfficientNet with TensorFlow backended. Adam algorithm were used as the optimizer. In this step, we totally got 4 trained models, and the models could recognize diffuse atrophy, patch atrophy, macular atrophy, and CNV respectively. When got these 4 models, we considered if we could make it more efficient and improve the specificity by some logistic process. So we tried to build a MetPM categorized system accordingly. We compacted these models and controlled by a routine procedure. In our opinion, when the eye suffer from patch atrophy or macular atrophy, the appearance of diffuse would be not important that much. But CNV is a major threat to the vision, so we reserved it as a separate condition. For example, an image was first processed by CNV and macular atrophy model. If macular atrophy negative, the image will be passed to patch atrophy model. If patch atrophy positive, the grading results will be called out combined with CLV results. Our models were evaluated by several indexes such as AUC, sensitivity and specificity, precision, and recall rate. We also compared the performance of models and system with 2 human graders, a specialist and a trade grader. In evaluating the generalized ability of MetPM categorized system, we had 2 external datasets. One is PALM dataset, which is mainly for high myopia image competition. Another one is SEED dataset, which is a official dataset from Singapore. Here is a table of clinical characteristics of cases with high myopia. We totally got 2,588 eyes for training and 1,844 eyes for test. For next, we will show you our results from each model. This is a case from diffuse atrophy model. Our model can recognize diffuse atrophy correctly. The accuracy reached nearly 90%. The model also marked the margin of diffuse atrophy. This is a case from patch atrophy. We can see a typical patch atrophy in the lower temporal side. The model could recognize the patch atrophy precisely. As you may also notice that the model voted peripheral atrophy as patch atrophy. This may caused by the similar appearance of PPA and patchy on fundus. This is a case from macular atrophy. We can see there was a large macular atrophy at the posterior pole. Our model can recognize macular atrophy correctly. This is a typical case for CNV model. We can see CNV scar at the fovea, and the model could recognize the CNV correctly. To summarize these results, we can see our models achieved a high accuracy, sensitivity, and specificity. But the sensitivity of CMV model was not higher that much. This may caused by the limited cases in our training data. Also, the appearance of CMV in active stage, scar stage, and atrophic stage were various. In our database, over 64% if CMV images were accompanied with macular atrophy, and the CMVs were in scar stage. So future studies on OCT-based myopic CMV detection is expected, and we are now on the way to achieve this. In evaluating the performance of MedPM categorizing system, the total accuracy was over 87%, which is corresponding to the myopia specialist and higher than the trained graders. When met the external dataset, the system also got a promising results, especially for the official dataset from Singapore. We got an accuracy over 88%. In conclusion, we used a large scale of fundus images of highly myopic patients to train deep learning models for recognizing myopic maculopathy and to build a system for detecting pathologic myopia. The novel models and system achieved a high sensitivity and specificity. We believe our work will assist the screening of pathologic myopia and subsequently protect patients from low vision and blindness caused by myopic maculopathy. Future work will address the applicability of MedPM category system in healthcare settings. Thank you very much for your attention.
Ultrafield OCT imaging of posterior vitreous and its implication of myopic traction maculopathy. Imaging vitreous is difficult because it is a large, transparent, and moving gel. As shown in the figures on top row, vitreous structure has been examined with autopsy eyes, B-scan ultrasonography, and magnetic resonance imaging. As shown in the figure on the bottom row, OCT enables us to examine microstructure of eye tissues, but scan range of conventional OCT has been limited. Since 6 years ago, we have conducted joint research with Canon. This ultraviolet OCT is swept source OCT and it's equipped with higher refractive index lens. This is 50-year-old female patient with idiopathic macular hole. On the ultraviolet field OCT images, we can see posterior vitreous clearly, and it detached from retinal surface except to the fovea. This machine is able to scan the fundus with 23 mm wide and 5 mm depth. Posterior vitreous of 448 highly myopic patients and 52 control patients were examined by this machine. In highly myopic eyes, posterior vitreous detachment develops more asymmetrically compared to normal eyes. Yellow arrowhead indicate posterior vitreous. Interestingly, the area of posterior vitreous detachment corresponds with the area of scleral protrusion in many myopic eyes. This is a fundus image of 56-year-old female patient. The vertical scanning image of ultraviolet OCT shows scleral curvature of posterior staphyloma and yellow arrowheads indicate posterior vitreous. As shown in blue arrow, vitreous traction causes paravascular retinal cyst at the edge of staphyloma. In highly myopic eyes, posterior vitreous adhere to the inner retinal surface at multiple points. It is multiple PVD. On these images, yellow arrowheads shows that long strands of vitreous were observed and seen to be floating. White arrow and blue arrow indicate paravascular retinal cases and paravascular retinal cysts, respectively. At the site of vitreal adhesion, retinal vessels are pulled anteriorly. As summarized in this figure, highly myopic eyes with asymmetrical eye shapes, a posterior vitreous detachment develops where the sclera is most outpouched posteriorly. And eyes with actual elongated barrel shape, PVDs, progress with irregular adhesion with retinal vessels. As a result, long vitreous strands extend perpendicularly from retinal surface. Next, we focus on myopic traction micropathy. It is a cause of vision impairment or pathologic myopia. Myopic traction micropathy develops in from 10 to 30% of adult highly myopic patients. The exact mechanism of myopic traction micropathy are diverse and complex. Ultraviolet OCT can help us to understand comprehensive pathology of the disease. We examined 150 highly myopic patients using ultraviolet OCT. As shown in this table, 49 eyes with macular retinal cases were older and has shorter action length and worse visual acuity than 101 eyes without macular retinal cases. In addition, eyes with macular retinal cases showed posterior staphyloma more commonly. This is a fundus images of 54-year-old female myopic patient. On horizontal OCT, white arrowhead shows that posterior vitreous detached from retinal surface except for optic disc. On vertical OCT, blue arrow indicates a vitreal adhesion to retinal vessel and paravascular retinal cyst. On ultraviolet OCT images, the presence of vitreal adhesion and paravascular abnormality was determined. As shown in this table, eyes with macular retinal cases develop vitreal adhesion onto retinal vessels, paravascular retinal cysts, paravascular retinal cases, and paravascular lamellar holes significantly. This is another image of 57-year-old myopic woman. On the wide OCT, white arrowhead shows that posterior vitreous detached from inner retinal surface, and vitreal foveal adhesion remains. On the other OCT scan, yellow arrowhead indicates that paravascular retinal cases develop in the multiple retinal layers around the retinal vessels, and blue arrowhead shows vitreal cortex thickening at the site of adhesion. These findings suggest that vitreous adhere to retinal vessel more widely and intensely than the other area. Causative factors for myopic retinal cases were determined using multiple regression analysis. As shown in this table, actual length and the presence of vitreal adhesion to retinal vessels are significant predictors for the myopic retinal cases. This diagram shows how vitreal changes alter the retinal structure at the paravascular area. First, PVD develops asymmetrically and vitreal adhesion to retinal vessel remains. Then, paravascular vitreal adhesion induces traction on retina and causes retinal cysts and retinal cases. Finally, retinal cases extended toward to the macular area, and occasionally is accompanied by paravascular lamellar hole. Ultraviolet OCT can obtain tomographic images of the posterior vitreous and reveal unusual vitreal changes over a wide area. Pathological vitreal changes can cause traction on the retinal vessel, which could result in the development of macular retinal cases. Thank you very much.
Good morning, everyone. Thanks for your kindly invitation. Today, my topic is intraoperative temporary perfluorocarbon liquid tamponade to reattach extensive retinal detachments secondary to myopic macular holes. Macular hole retinal detachment is prevalent among extreme myopia population. The affected eyes have a lower chance of macular holes closure after a single PPV because of large macular holes, vitreoretinal traction, staphyloma, and atrophy of RP and choroid. Thus, various techniques have been established, including insertion of IRM flaps, lens capsular flaps, injection of blood, and etc. to seal the macular holes. However, if the retina is already highly detached, operations on macula are so difficult that they usually require assistance of peripheral common liquid tamponade. Meanwhile, drainage of subretinal fluid through macular hole in BSS field eye is insufficient to reattach the retina. Extramacular therapeutic breaks for subretinal fluid drainage are usually needed. Here, we report a novel technique to facilitate macular operations, temporary PFCL tamponade to reattach retina during the surgery. 9 patients with myopic MHRDs who received the PPV and the technique were reviewed. Of them, 8 eyes developed total retinal detachments, and 1 eye had retinal detachment involving 3 quadrants. Peripheral breaks were excluded. 4 of these eyes had undergone a prior PPV, and 2 eyes had IRM peeling. Here is a typical case with a large macular hole and total retinal detachment. Visual acuity was hand motion. First, we flattened the retina by drainage of subretinal fluid in BSS field eye, followed by a fluid air exchange. Second, we inject 1 to 2 milliliter PFCL into the vitreous cavity and on the posterior retina. Air fluid exchange is performed so that the eye is filled with a PFCL bubble in the lower part and BSS in the upper part for at least 10 minutes. Third, we remove the PFCL bubble. The retina is reattached. We do operations to seal the macular holes. This video showed how the retina was reattached by the temporary PFCL tamponade technique during PPV. First, we did a co-vitrectomy. Then we drainage of subretinal fluid from the macular hole. And the pinning of the posterior hyaloid completely. Then we do a fluid air exchange. Peripheral common liquids was injected. Then we do a air fluid exchange. Shaving of the vitreous base. Staining of the IRM with ICG, and then remove all the PFCL. Then we do IRM peeling and inverted IRM flap insertion. Inject autologous whole blood. Finally, we did fluid air exchange. After 3 months follow-up, the images showed healed macular hole and reattached retina. Visual acuity was improved to 20 to 150. Here is the video showing how we reattached the retina in the eye with an unclosed macular hole after the first PPV. Also, we drainage of subretinal fluid from the macular hole. And fluid air exchange. Inject PFCL and do a mechanical PVD totally. Shaving which is base completely. Staining of the IRM with heavy BBG. In this case, it is very lucky. There is a residual IRM. We enlarge peeling of the IRM and get a free flap IRM and insert it into the macular hole. Coating the macular hole surface with whole blood. Finally, we did a fluid air exchange and inject C3F8 gas. The patient achieved the closure of macular hole, reattached the retina, and improved visual acuity. Intraoperatively, PFCL tamponade lasted for 10 to 38 minutes. Retina was reattached and immobilized in all eyes after PFCL removal. Operation on macula included epiretinal membrane peeling in 3 eyes, IRM peeling and flap insertion in 7 eyes, lens capital flap transplantation in 2 eyes. C3F8 was tamponaded as a substitute in all 9 eyes for the surgery. During 6 to 12 months follow-up, all 9 eyes achieved closed macular holes and reattached the retina after the surgery. To summarize, key points of the technique are as follows. First, we do a sufficient drainage of subretinal fluid before PFCL tamponade. Second, we need enough time for PFCL tamponade to encourage RP retinal adhesion, especially in eyes with severe atrophy of RP and choroid. Third, we try to relieve epiretinal tractional membranes before PFCL removal. The technique is effective to partially reattach retina in eyes with retinal shortening, and it can facilitate macular operations. Silicone oil tamponade may improve the closure rate in such difficult cases. Thank you for your attention.
Hello, everyone, and a warm welcome to the Asia Pacific Myopia Society second annual conference. At the outset, I would like to thank Professor Martin, Professor Lam, and Professor Chow for giving me an opportunity to talk at this featured symposium on high myopia complications. I'm Dr. Nishant, and I'll be talking about the role of a VR surgeon in the screening of retina for prospective refractive surgery patients. I don't have any financial disclosures. At the outset, this is the structure on which I'll be modulating my talk. This is the outline, why and how of the screening, the requirements, the common refractive surgeries, myopic retinal degenerations which can predispose to loss of vision, some guidelines, some of our experiences, some unmet needs that I have thought about, and a possible proposal for the Asia Pacific region specifically. We normally use an indirect ophthalmoscopy with scleral depression to do a thorough examination of the retina. Some places they use a contact mirror lens, 3-mirror lens. The SLO has quickly started replacing the need for making detailed retinal diagrams because it's a nice way to document with clock hours each and every lesion possible, and it can be a good way not only to document but also to try and compare how the things evolve in future. Sometimes some patients are allergic or they refuse dilatation. SLO can still take good numbers, good images in that. Coming to the requirements, it has been seen that the refractive surgery devices market has been growing at an exponential rate. And more and more people are getting the desire to get operated and become glasses free. According to the World Health Organization, high income countries of the Asia Pacific region are seeing an increased prevalence of myopia. According to the World Health Organization, nearly 50% of the world's population is expected to be myopic by the year 2050. So these are big numbers. And the common surgeries that are done, which may be associated with the retinal detachment, are LASIK, SMILE, or the implantable collamer lenses. Although the occurrence of retinal detachment is not very high, the reason primarily behind that could be the fact that such patients are usually subjected to retina screening. Some common retinal degenerations which can lead to loss of vision are lattice degenerations, retinal holes or horseshoe-shaped tears, and presence of myopic maculopathy. Lattices are fairly common, seen in almost 8% of normal individuals. However, almost 30% of the retinal detachments are associated with a lattice, and nearly half of patients with lattice in one eye will have a lattice in the other eye. Prevalence of lattices have been found to be more in patients with high myopia, almost 17% as compared to almost 8% of normal population. Retinal holes are much less common compared to lattices, and no study has ever found any statistically significant difference between the normal population and high myopes. Asymptomatic or atrophic holes can be closely monitored with thorough explanation to patient. Horseshoe-shaped tears, on the other hand, suggest dynamic traction because there is a flap which is getting pulled by the vitreous. Patients may or may not be symptomatic, but prophylactic laser is best in such patients with horseshoe-shaped tear. Maculopathy is a relative contraindication. A big meta-analysis from China revealed that the prevalence of myopic macular degeneration in the entire world population is around 2%. Macular holes have been found to occur after LASIK surgery, and presence of lacquer cracks or CNVMs has also been seen after refractive surgeries. An interesting study by Wang et al. Found that the use of femto laser to create a flap was associated with a higher risk of PVD, not because they used higher suction. In fact, the suction was less, but because the suction lasted for a little longer time as compared to the manual keratome-based flaps. These are some guidelines given by the AAO which are universally followed, where they usually treat dialysis or horseshoe-shaped tears in a patient with symptoms, flashes or floaters primarily. And they are fairly conservative about treating other patients because every treatment has its fair share of pros and cons. And all patients with lattices don't necessarily land up with a retinal detachment, or atrophic holes without any vitreous overlying traction can be safely observed. Nearly 70% of patients with a vitreous hemorrhage in a case of acute PVD will have a retinal tear, and almost one-third of these will have multiple tears. So these are some important tidbits we need to remember, which are usually followed by the world when it comes to treatment of PVD and PVD-associated breaks. These are some cases that we came across. This was a young female who was an asymptomatic myope who was referred to us in the retina department for pre-refractive screening. There was a very early lattice with not much of overlying vitreous traction, which we saw. She underwent a SMILE surgery without any prior treatment because the lattice was not having any vitreous traction and the patient was asymptomatic. Unfortunately, a month later, she landed up with a retinal detachment localized, and we had to do a retinal detachment surgery, put gas, and fix the case. She did well afterwards, but this is a case where even if we follow the guidelines, we may still land up with a problem. So myopes may behave differently. This case was a routine pre-LASIK screening patient who was referred. The patient was unsure whether he actually had any floaters or flashes. But on examination, we found that there was a superior localized RD with a lattice and hole. We advised him to undergo some prophylactic laser first, followed by pneumatic retinopexy. Pneumatic retinopexy helped and the retina was attached. The patient follows up with us, and after the retina was well attached, the patient underwent LASIK surgery. CNVM or lacquer cracks may be seen as well in patients with high myopia, and this was a patient who was referred to us for routine retina screening from the LASIK department, and there was a lacquer crack looking lacquer crack type bleed which was seen, but the OCT was a little confusing because we suspected a small CNVM. So an angiography was done which confirmed the presence of CNVM. Patient received anti-VEGF injections and recovered well, but decided not to go ahead with the refractive surgery. This was another patient who came to us during a routine screening. The retina was looking innocuous as if there is nothing, but the OCT revealed presence of myopic traction maculopathy. Since the vision was good and the threat to the fovea looked imminent, we advised him not to undergo any refractive surgery at that time. Soon he landed up with a outer lamellar hole, and then he had to undergo a vitrectomy. He maintains good vision. This was an interesting patient as well. We had noticed a small subclinical RD with a lattice as well in the upper area. We advised him laser, but the patient didn't follow up with us. He underwent LASIK elsewhere and came to us a few months later when he landed up with a retinal detachment. So he had to undergo surgery, and then we had to fix his retina. What these examples taught us is, or taught me rather, is that there are some regional variations and there are some racial variations. Asia Pacific region has higher prevalence of myopia, and we have to be tailor-making treatment for patients who come looking for refractive treatments here. So perhaps we may need to treat a little more often. That is my thought. This could be a proposal from the Asia Pacific Myopia Society. Thank you and stay safe.